So we're here in Nashville, Tennessee, in 2025. It's the Uromigos meeting, and I think we had an extraordinary bladder cancer ESMO, maybe the best bladder cancer meeting we're ever going to have. 3 presidential sessions, and one of those sessions was by Jungo and the Chinese DV toripalimab trial. Before we kick into that, why don't we introduce ourselves? Michiel, firstly, welcome. Thanks for joining us. Do you want to introduce yourself?
Thank you. I'm Michiel van der Heijden. I'm a medical oncologist from Amsterdam, the Netherlands, and super thrilled to be here in Nashville.
We're super thrilled you're here. Well, I'm thrilled. Shilpa, are you thrilled too?
I'm Shilpa Gupta from the Cleveland Clinic, and thank you for inviting me again for the 4th year in a row.
You're always welcome. Always welcome here. So let's look at this slide really quickly. We're not going to dwell on it for too long a period of time, but we're just going to talk about the DV toripalimab in red for a second, and I'm going to go through the data very quickly. Essentially, we had a randomized phase 3 with disitamab vedotin. Disitamab vedotin targets HER2, and it is a trial which was only in patients who were HER2 1, 2 or 3 plus. It was in China. It turned out to be 80% of the population. It was combined with a PD-1 inhibitor that's widely used in China called toripalimab. It was compared to chemotherapy in first-line metastatic disease. The patient characteristics were classic first-line metastatic, maybe slightly higher incidence of upper tract disease. But the key was the hazard ratios came in for EFS at 0.36, for OS at 0.54. It says on the slide EVP, it should be DVT. I apologise for that if you're watching. And so that's all in red, that's DV toripalimab. And then you've also got this path CR rate. You've also got this response rate of 75% with a CR rate of quite low at 5%. When we look at the EV Pembro data, this is a similar patient population but unselected individuals, and the hazard ratios very similar. Some people say maybe the DV toripalimab didn't have maintenance of avelumab in it. Other people say DV toripalimab had a lot more subsequent ADC therapy. When you look at the overall survival of both groups, they're coming in at about 30 months. And so overall, you look at the 2 trials, many similarities. EV Pembro, longer follow-up as well. Slightly different toxicity profile. I think Nectin-4 is associated with more skin toxicity. I've done quite a lot of DV. I've seen quite a lot of neuropathy and some fatigue as well. So neither is a walk in the park. Both continue until progression. Let's bring that slide down now, and let's just talk a little bit about what you made of. Let's start with you, Michiel, on DV toripalimab, and then Shilpa ask you about how you compare the 2 regimes.
Yeah, so this is, I think, a great result, great trial. My first response to this was, this is a complete copy of EVP in terms of results, so it looks very similar. We can have a long discussion about some of the differences between these, but I think the results are completely in line with EVP, and it would be difficult to say which one would be superior than compared to the other.
CR rates of 30% in one, with duration of response of 23% for EV Pembro, 5% with shorter duration of response in DV toripalimab. Does it worry you that the duration for DV toripalimab is not quite the same as EV Pembro?
Well, I think in the end we look at the PFS and the OS, and they all seem to be in line with each other. So I'm not concerned at this point that there's a huge difference. I would assume that we will also get an update just with EVP in a year or so. For the CR, I think there's been a lot of talk about it. I think this is going to be more of a difference in some of the study methodology probably than a real difference in efficacy. There was a small trial already done in a non-Chinese population which showed higher CRs. I think that's what we'll see in the confirmatory non-China randomized study is my expectation. So as long as PFS and OS are what they are, I wouldn't be too concerned about that.
Shilpa, HER2 selected patients, if you don't, EV Pembro, you don't have to select patients. There was no enrichment in the HER3 plus for OS or PFS. that questions whether the biomarker works. In our discussion, we said, are we confident it doesn't work in the HER2 zero patients? Matt Gowski and Jun Go said in China there's data on the 0+ in small numbers, doesn't look great. Are you convinced by this biomarker, or are we not sure yet?
I don't think we are sure yet. To your point, Tom, those were very small numbers. We can't really say that in HER2 zero it won't work. Just like in the breast cancer, we're seeing that the ADCs are working even in HER2 negative or ultra low. And having said that, we really don't think that HER2 is enriching the responses, because like you said, HER2 3+ did not do much better than HER2 1 or 2+. So to me, the bigger question is, how did the patients with HER2 positive tumors in EV3 or 2 do? And that may show us that it really doesn't matter, but regardless of the biomarker, it's good to have an alternative option.
Shilpa, I'm going to stick with you if I may. You've given a lot of EV Pembro. The DV toripalimab, maybe less skin tox, I think probably less skin tox. There was some transaminitis, there was some fatigue, and there was some neuropathy. When you look at that picture, and we give these drugs to progression, we don't stop, and Michael, I might ask you a second about discontinuation, early discontinuation, but how long do you give these drugs for? And does looking at that DV tox profile think, oh, this looks a bit better? Or do you look at it and think, actually, similar problems, similar challenges, dose interruptions, dose reductions, how long do we go for?
Yeah, I think about EV Pembro, as you know, the study mandated that there was no stop duration for EV, but Pembro was for 2 years. But in real world, we know we really can't continue EV indefinitely. We showed the data at ASCO that median number of cycles was 9. Despite those discontinuations and interruptions, the benefit continued. So I think we need to really start thinking about de-escalating that and re-challenging with EV if patients were to progress, like an intermittent approach. On this study, I was surprised to see that the neuropathy rates were lower, and I don't know if it's an underreporting problem in just the Chinese population or what it was, but I would think that continuing it till progression, and we need more data on the toxicity, long-term effects of that.
Mikhail, I'm going to move on from that, but just before we do move on, I wanted just to talk about subsequent therapy after DV and EV Pembro. We talked in the session about cross-resistance between the two, potentially, because the payload seemed to be driving cross-resistance, not the target. Would you sequence EV after DV? And if you were not going to do that, what is the standard of care currently?
So I think at this point we have really insufficient data to advise to switch from EV to DV or the other way around. I think, well, basically for any treatment we lack data, but I think the most logical in this situation is to give second-line platinum chemotherapy, and I think in trials that we will be doing, that should be the standard arm for trials. So I think that's what I would stick to. I can imagine that in the end my feeling says it's more chemo resistant that develops, but even there we don't have enough data. But I think in later lines, if you've given a couple of other lines and we want to give it a go at that point, I think maybe that would be reasonable. But at this point we really lack the data to recommend giving the same.
Is it still the case that you get one good go at bladder cancer? And
absolutely.
Still the case to use your best treatments first?
I think that's what we're seeing here, and what we'll talk about later lines, but really the jackpot for a metastatic urothelial cancer patient is long-term remission and perhaps cure, which I do personally believe in, and I think that we can reach that potentially in about a third of patients. I think that's the number that we really should focus a bit more on, that we can raise that number, because that's really what patients are looking for.
I want a quick yes or no answer from both of you. Re-challenge with immune checkpoint inhibition, yes or no?
No.
In principle, no, only in very, very select cases.
Okay, so we're going to change gears now if we can, and we're going to talk about an ADC trial that didn't work. So TROPiCS-4 was a study that looked at sacituzumab govitecan. This is a Trop-2 ADC, and it has a topoisomerase payload. That trial was against taxanes in heavily pre-treated patients, and it missed overall survival as its primary endpoint. Other similar drugs with a similar mechanism of action Dato-DXd and sac-TMT are both similar agents. They have somewhat similar efficacy analysis or efficacy data. The Dato-DXd we know is now in a randomized trial of Dato-DXd plus carboplatin versus Gem-Cis or Gem-Carbo. What went wrong with the sacituzumab govitecan trial against taxane Shilpa? Does that mean the whole class is problematic, or is it specific to that particular drug?
I think for the sacituzumab govitecan, initially in the Trop-2 we saw some activity. It was modest. It wasn't what we saw with monotherapy EV. And I think in the phase 3 trial, it really did not have any efficacy better than the salvage chemotherapy, and furthermore, it was toxic with some toxic deaths in this arm. I think it's probably to do, even though they're all targeting Trop-2, it's probably to do with the linker, and it's possible that the Trop-4 was mainly ex-US. We don't know how those patients have the UGT1 metabolism and how they metabolize their drug. So I think those factors we still don't know much about, and of course, there was some lack of growth factor.
So GCSF was changed during the conduct of the trial. There was neutropenic deaths initially. And Mikhail, do you think the class of drugs, should we keep going with these two other agents? Do you think that they're all the same, or have we got better things to do with our time?
So I think there is some activity clearly of these topoisomerase inhibitors in bladder cancer, but not like vedotin, where there seems to be something special with vedotin.
It's the other way around in breast cancer.
It's the other way around in many cancers,
Yeah.
it seems, but it's also even in those cancers, it's not like the enfortumab vedotin combinations that we see in bladder cancer. So I think we will get modest benefits if we get the dose and the drug right in the right trial. We will see probably a positive trial. I think these are modest incremental improvements. This is not changing the face of bladder cancer as we've seen in the last years with these new combinations.
When we talk about changing the face of bladder cancer, on this slide you can see a plethora of drugs we've not talked about before. We're not going to go through all of these in detail. The Bicycle drug is also in randomized phase 3, frontline, very similar to the EV Pembro trial. We've not heard from that. Isobren is another trial. This is a HER3 EGFR topoisomerase targeted drug. That's also in randomized phase 3. We talked about Dato-DXd, the sac-TMT we've discussed. This slide really just tells us how exciting this field is. Are there more similarities than differences between these drugs, or are they complementary? Should we be combining them, or should we be sequencing these agents? Shilpa, why don't you start with me on that?
I think, all these are exciting agents, and there may be more similarities than differences. It depends which trial is using it in which setting. And I really don't think we need to adapt the kitchen sink approach just to throw all the ADCs at one go. I think we need to understand what sequence may be the best use for the patient, minimizing toxicity as well as financial toxicity.
Michael, there's some possibilities of some combination trials. Sacituzumab govitecan, sacituzumab govitecan plus enfortumab vedotin have been used in combination with 70% response rates. You talked about trying to cure bladder cancer. Is that the best next step by using ADC doublets with immune therapy, or do you think it's too ambitious?
Well, so we are seeing now an enormous range of ADCs coming out, and I think there's huge development in China, a lot of ADCs coming out. I think at this point we see drugs that seem to do a bit better than what we've seen with sacituzumab govitecan, but not a terribly lot better. I think these will improve, but we are, for decades we've been trying to change the face of bladder cancer, which was most people dying within 1.5 years, and we're now seeing long-term remissions, and now we actually are at a point where we can start thinking, what is the trade-off between toxicity and long-term benefit, and I think we should focus more on this long-term benefit, because what's happening now is we're doing small trials with 40 patients, sometimes less. We look only at response rate and maybe in the short run a duration of response, but we're not really looking at are we improving the long-term outcomes of our patients, and I think that's what we should be focusing a bit more on. And we're now only focusing on developing more and newer ADCs.
These are trials at the moment that are ongoing.
And can I add one
Yeah,
thing?
of course.
That, like in the DV-TORI trial, we saw that irrespective of the CR rates, the PFS and OS was better. So maybe we don't need to get hung up on just response rates and throwing more drugs together for that.
I'm inclined to be ambitious and add the third drug and see if we can do. That's an experiment that's worthwhile doing. I'm not sure it's going to be successful, but I think we have this armory of agents, and dare I use a testis cancer analogy. We had one drug that was good, and then second added, and then third. So I think we should do the experiment. I'm not convinced they're going to be positive. There's going to be a big toxicity signal. These are the randomized phase 3s that are ongoing. We've discussed many of these randomized phase 3s, but I think it is worthwhile looking at. There is the perioperative studies with EV Pembro versus Gem-Cis. There's the perioperative trials with only 3 cycles of neoadjuvant therapy rather than 9. That's the Volga trial, so those are asking slightly different questions. Then the frontline metastatic, the DV Pembro feels like a Me Too trial that we just talked about, Jungo. That's a global trial though, so that's for, I guess, European and American approval, I would imagine. And then here we talked about the bicycle Nectin-4 MMAE. That feels very similar to EV302. Those trials need to enroll really fast because I don't think the control arm is, even dare I say in the UK where we have difficulty with access to drugs, we can't enroll to these trials because we're using EV Pembro. But the IO experience one, we've talked about the HER1, HER3, Topo1, Isobren trial. And that is a second line trial post EV Pembro. We talked about Dato-DXd plus carboplatin against platinum chemotherapy. And then there's a third trial which is exploring IO re-challenge with SG, with sacituzumab govitecan. On the green box, Shilpa, which of those 3 trials are you most excited about?
The top one, the Isobren, because the control arm is a solid control for platinum, which we are using in second line, and Isobren, and the experimental arm sees reasonable. The other 2, combining platinum with the Dato-DXd versus platinum doublet is not that appealing to me.
Michael, you look at that picture, what are we not doing that we should be doing?
That's an excellent question. I put the question out there. We should be looking more at the long-term durability of our treatments, but to be fair, I don't really have the answer. It's a very dangerous thing to say. I think I presented at ESCO the Ipi-Nivo trial, which was a negative trial, but everybody was seeing the data. Has also seen that the long-term durability of patients in the Ipi-Nivo arm was quite good. Maybe there's still a role for anti-CTLA-4, but clearly we have to do something better there with our trial design, but also with our combination. So I think we should put at least some focus on which combinations can really change the durability of response, because that's what patients want. They want to,
My last question to you both, it's a one-word answer. With ADCs, is it biomarkers or combinations?
Combination.
Combinations. Thank you very much indeed.
Thank you.
Thank you.